reproductive pathology. So for this reproductive pathology video, we're going to be talking about functional hypothalamic amenorrhea as well as PCOS, polycystic ovarian syndrome. So for functional hypothalamic amenorrhea, what happens is that we have a decrease in the pulsatile secretion of GnRH from the hypothalamus. And we said that the pulsatile secretion of GnRH is very important in the release of sex hormones, right? If we lose that pulsatility, then we have an overall decrease in LH and FSH as well as a drop in estrogen. And so that's precisely what's happening with this pathology. And the reason we have a loss of this pulsatile nature of the GnRH secretion is either due to two things. It's either due to one, a decrease in weight, or two, an increase in stress, okay? And now it's associated with eating disorders or the female athlete triad is what they call it. So if a patient has an eating disorder, or if the patient is a severe like running trainer, she trains to be in the marathons or weightlifting, okay, and she works out like 14 times a week or 18 times a week or 20 times a week, something crazy, right? Then you're going to see a decrease in caloric availability with excessive exercise, an overall decrease in bone mineral density, and that's going to lead to our functional hypothalamic amenorrhea, which causes menstrual dysfunction, all right? So the patient's normally going to present, the vignette is going to say, the female had her menses already at the age of like 14, they'll say, or 13, and then she hasn't had her menses now for the past 6 months, and she's like now 20. So if you randomly have a stop in your menses, even though you've already had a normal start thinking about functional amenorrhea, right? Functional hypothalamic amenorrhea. And then they'll specifically add something about severe weight loss secondary to an eating disorder, or two, severe weight loss secondary to working out a lot. They'll say that she's training for a marathon, okay? So that is very, very important for functional hypothalamic amenorrhea. It's something that they love to quiz us on, test us on, but it's relatively straightforward, okay? So whenever you have that loss of pulsatile function of GnRH, you're gonna have a drop in the estrogen, which leads to amenorrhea, and overall, it's usually caused by decrease in weight and increase in stress. Next is polycystic ovarian syndrome. So PCOS is very common. You hear about it pretty much in all the news recently, right? Everyone talks about PCOS, specifically that Ozempic could be a treatment for PCOS. Now, we'll get to that later on. It's really not relevant for boards or step one, but it's just something that's interesting. So let's talk about PCOS and what you need to know for boards. All right. You're going to see hyperinsulinemia or insulin resistance, okay? And so that leads to an increased risk of diabetes. All right. And so that's the first thing that you have to understand with PCOS is the first thing seen is that you have an increased risk of diabetes because you have hyperinsulinemia. There's too much insulin within the body, or you have an increased insulin resistance. Now, another thing you have to know is that you have an increase in LH to FSH ratio, as well as an increase in androgens. And that's going to lead to an overall amenorrhea, as well as kind of hirsutism within the female that has PCOS, okay? Hirsutism and acne because of that hyperandrogenism, all right? It's associated with obesity, all right? And they have an increased risk of endometrial cancer. Now, you're probably wondering, how can I spot this patient when I'm reading a vignette? So I kind of narrowed it down to three things. PCOS is going to present with one, enlarged or cystic ovaries. Okay, so they will say there's presence of enlarged or cystic ovaries on ultrasound, all right? That's number one. That's why they call it polycystic ovarian syndrome, all right? So because they have enlarged and cystic ovaries. Number two, you can see an increase in androgens, specifically testosterone floating around in the blood, all right, which leads to the hirsutism and acne. And number three, they'll have amenorrhea or dysmenorrhea. So they haven't had their period, or their period is very odd in the way that it comes about. They'll tell you that the patient has come in and they have their period or they have their menses about, once every 3 months, and it lasts like 3 days. Okay, and that's how the patient's gonna present. If you see dysmenorrhea like that, and then they also give you a little bit about she might be overweight, she might have hirsutism or acne, and then they tell you about hyperinsulinemia with an increased LH-FSH ratio. They're talking about PCOS, okay? You have an increased risk for endometrial carcinoma in patients that have PCOS, as well as the treatment is very important, okay? So OCP treatment is gonna be able to use, especially because we could treat hirsutism with OCPs. How do we do that? If we give them OCPs, that leads to overall decrease in LH. If we decrease the LH production, that leads to a decrease in androgen production, and that causes a relaxation on the hirsutism symptoms, okay? So let's take a step back, right? So if I give them OCPs, and all OCPs, right, they're gonna be our birth control, okay? So if I give a patient a birth control pill, it's gonna lead to increased levels of estrogen in my body. Increased levels of estrogen in my body lead to a negative feedback mechanism that causes a decrease in LH. Decrease in LH will lead to a decrease in androgen production and overall decrease in our hirsutism symptoms, okay? Very important. They like to ask about that. Now, finally, that we're done with this topic, I could talk about just Ozempic, Now they say Ozempic can solve PCOS, it can cure PCOS. Well, the reason behind that is because PCOS is highly associated with obesity. So if you're able to solve obesity's problems, right, then you're able to figure out the cure for PCOS, right? If you're able to solve obesity, then you can cure PCOS. Okay, so keep that in the back of your mind. Now, I want to take a step further and kind of explain why you are infertile, okay? It decreases fertility in females and it increases the risk of endometrial cancer. If we think about it this way, patients that have PCOS are associated with obesity, right? Because they have the hyperinsulinemia, they have the increased insulin resistance, they're obese. What did we say are the 3 locations where we produce estrogen within the body? We produce it 1 at the ovaries, 2 at the adipose tissue, and 3 at the placenta. Well, in these patients, we have tons of adipose tissue because of obesity. And because we have those increased amount of adipose tissue, that means we have increased production of estrogen. The increase in production of estrogen is going to lead to 1, my increased risk of endometrial hyperplasia and carcinoma, right? Because what do we say estrogen does? Estrogen is the crazy one that leads to the growth of the endometrium, right? And number 2, the increase in estrogen from the adipose tissue is going to lead us with our decrease in fertility in females. Why? Because it's not the right estrogen. The estrogen that's being produced is coming from the adipose tissue, not from the ovaries. And so it leads to overall decrease in LH and FSH. And so we don't have LH and FSH acting at the ovaries to produce estrogen. So that's why we have problems with fertility. Okay? We don't have that normal cycle of the estrogen coming up and increasing and increasing and increasing, and then finally the LH surge happening. No, the LH surge cannot happen because we just have just a normal amount of estrogen that's constantly being thrown into the blood by the adipose tissue. And so it's just throwing out of whack the whole entire menstrual cycle. All right, and that's why you see dysmenorrhea. Okay, so keep that in the back of your mind. PCOS, once again, has those enlarged polycystic kidneys, increased testosterone and androgens, and they have dysmenorrhea or amenorrhea, and they have the increased risk of endometrial carcinoma. They have hyperinsulinemia, insulin resistance, and OCPs are able to treat the hirsutism and acne seen because it decreases LH, leading to an overall decrease in androgen production. All right, that's all for this pathology, and next are going to be our ovarian tumors.